So without further ado, let's go ahead and get started. I'd like to introduce our project officer for the National Center on Substance Abuse and Child Welfare, Ms. Sharon Amatetti, who will begin our webinar.
Okay, thank you very much, and hello everyone. Thank you for joining the webinar today. We have an unprecedented number of individuals who registered, over 2,500 from throughout the country, and that's really quite astonishing, and it speaks to the volume of the epidemic that's affecting many of our communities. We're delighted to have all of you joining today's live webinar. As evidenced by the large number of you that are in attendance today, the opioid epidemic is affecting and sometimes devastating families and service providers from virtually all of the health and human services. This is demonstrated by the diverse group joining us today. We have professionals from child welfare, substance use disorder treatment, pediatric care, obstetric care, maternal and child health, early childhood education, home visiting, mental health, and others. So we're so glad that so many of you could join us. I hope that you leave this webinar with an invigorated sense of being able to do something about the opioid epidemic and with some ideas about what to do moving forward. I'd now like to turn this over to my colleague, Elaine Stett, the Director of the Office of Child Abuse and Neglect at the Children's Bureau at the Administration for Children, Youth, and Families. Elaine?
Thank you, Sharon, and welcome everyone. Sharon and I are so proud to be here today together to bring you this webinar with the National Center on Substance Abuse and Child Welfare. The National Center was founded 15 years ago and, as Sharon said, is co-funded by the Substance Abuse and Mental Health Service Administration and the Administration for Children and Families Children's Bureau. At the core of the National Center is a fundamental understanding of collaborative practice as the key to effectively working with families affected by substance use disorders. This fundamental understanding is learned from 20 years of practice spanning numerous drug epidemics and 15 years of collaboration between SAMHSA, the Children's Bureau, and our work through the National Center. As illustrated on this slide, we have learned through various efforts that collaborative work between family service providers are critical to improving outcomes and halting intergenerational cycles. Today's webinar is based on lessons learned from 2 decades of applying collaborative practice and lessons learned. I am so very pleased to introduce Dr. Nancy Young. Dr. Young is the Director of the National Center on Substance Abuse and Child Welfare and is truly passionate in her work on behalf of families affected by substance use disorders. Thank you for your interest today, and I will turn it over to Nancy.
Thank you so much, Elaine and Sharon, and thank you to all of you in the audience for your interest and the commitment of your time today to share with us with some knowledge and some efforts that the National Center has had underway for some time, and looking specifically at families that are affected by opioid use disorders and infants that experience prenatal substance exposure. A couple of things on our agenda. We're going to spend some time on the data and then turn our attention to that knowledge base that I mentioned from working with states and communities and putting together services to support families. We'll talk a bit about what have we learned about collaboration, as Elaine said, that becomes so critical for working across those systems and building those bridges. And then we'll have some time for some questions. So please do submit questions through your chat box. And we have some staff that are monitoring those, and we'll round them up towards the end and have some time for some questions. So let's get started. So what's different about the opioid epidemic? What do the data say? And how is the opioid epidemic affecting children and families? Let's see if we can answer some of those questions in understanding the data. Yeah, this isn't necessarily a new phenomenon in child welfare practice. When we go back to previous decades, we had the heroin epidemic of the 60s, certainly the cocaine of the 1980s, when many initiatives that you've been operating in your communities got started as we began to really focus on the issues of cocaine and prenatal exposure. And then moving into the 1990s, the methamphetamine epidemic, which again generated much attention to families in child welfare practice. Again, many of you have been working since that time to understand how to put practice and policy together in a way that makes sense for families. But this seems to be something a bit new, new again in the 2010s as we began to grapple with the prescription drug epidemic and to understand what that means for families affected by opioid use disorders. Clearly, one of the major differences is the overdose deaths that are involving opioids. You see on the screen that rate for any opioid overdose death, as well as then the various lines at the bottom for those that are affected by the various types of prescribed opioids, as well as the more recent information that we have, and you see that skyrocket from 2013 with other synthetic opioids that are at the root of many of the overdose deaths. But you also note that the heroin has been on the steady incline since 2000. The opioid deaths quadrupled from 1999 to 2015, and disturbingly, there are an estimated 142 deaths per day. In 2015, heroin deaths surpassed deaths by the other kinds of prescribed opioids, hydrocodone and oxycodone, and the surge that your communities and our country has been experiencing in heroin and fentanyl-related deaths. So this is different for child welfare. It's different in that we have many more grandparents and many more children that have lost one or both of their parents, and so different kinds of interventions for them. The main driver of those drug overdose deaths are prescription and illicit opioids, and you see data from the Center for Disease Control on the changes between 2014 and 2015 in the states with the statistically significant increases. And I recognize that many of you are in these states and working with families every day who may have experienced this kind of loss in their family. When we look at those with the highest rates of drug overdose deaths, clearly we've all seen this in the news. Some of the states in the Northeast Corridor, as well as Ohio, West Virginia, and Kentucky, with the highest rate of drug overdose deaths. So this isn't necessarily news to many of the people that are on the webinar today, because we've been experiencing this in our communities for a while, as well as the media that has paid a great deal of attention, particularly to those states that have the highest rates of drug overdose deaths. Let me turn now to the data related to child welfare. This is that same year, the 15 years of trend data of children that are in out-of-home care. This is a point-in-time census at the end of the federal fiscal year. And after a decade of initiatives in child welfare practice, responding in some ways, it was responding to the Adoption and Safe Families Act and many other practice changes and policy changes that states implemented to decrease the number of kids in out-of-home care. And after that 15 years, we began to see that uptick in 2013, that more children living in out-of-home care in these last few years. When we look at the data from the information that is provided from states to the federal government, there's a variable in all of the states' data sets about the parents' alcohol or drug use as a contributing factor for the reason for removal. Now, if we were in person, I would ask for a show of hands about how many of you experience about a third of your cases that have parental alcohol or drug use as a factor in the case. And typically what I hear in every state I've been to, frankly, is that that doesn't account for all of the parents with substance use disorders in child welfare. And this is, we think, the reason why. These are those same data items that are submitted to the federal government by state. Now, we don't necessarily think that states, sometimes that neighbor each other, have the very big variation that you see in the prevalence of substance use in their child welfare cases, ones that are removed. Rather, we think that there are a couple things that are going on. The states that have a systemized way of universal screening or have implemented standardized screening tools are the ones that we often see with those higher prevalence rates. But what we've learned is that it's not just having the way in which we're identifying parents, it's also this issue of the data collection system. It's sometimes a complex way in which these data are collected in the intake. Sometimes the procedures from the initial removal to during the identification in a family assessment are perhaps at the time of the disposition hearing that data collection is to take place. But there's typically not a standardized protocol for how to record those data in the information system. That results in that chart that we just saw with that wide variation from state to state about the prevalence of substance use disorders. We know it's state to state. We actually know it's county to county and sometimes worker to worker in the variation of actually identifying that parents have a substance use disorder as well as entering it into the data system. In states that we've looked at these same data, sometimes in counties in which they have the highest overdose death rate in their state, they report 0 children coming into out-of-home care. Now, you may say, well, you're belaboring that a bit on all of the data, but we think it's critically important. At the National Center, I can't even tell you how many technical assistance or questions we have fielded about what is the impact of opioids on the child welfare system. And without the system to record those data, we may look at that slide that looked at the epidemics across the decades and look back at this in 10 years and say, we didn't take that opportunity to really understand our information systems and to really understand how we needed to make those changes. Another fact that is a bit disturbing is data that you see the reference from Dr. Kristen Say, who published in the Child Welfare Special Topics Journal that was released about a year ago. And she reviewed all of the prevalence studies that were published and found that there had not been new research on the impact of alcohol and drugs in the child welfare system for a decade. She also analyzed those same data that we just mentioned from the AFCARS data set that are submitted by state. So we have more recent data, but it's very tough to do good studies about what's working when we don't have good data about which families. So again, belaboring the data issue a bit, but it also comes into play with this issue related to infants. So these are the same data set looking at that same indicator of parent has an alcohol or drug problem. And remember that national average was about 34%. When we look at just the children that were in out-of-home care at some point during that federal fiscal year, you see that it's 45% of infants, children under the age of 1 who are entering out-of-home care. And in 2015, we know that the age of children who entered is largely infants. When you look by age, that less than, that these are of entrance into out-of-home care, approaching again the 50,000 coming into out-of-home care in 2015. Now, there clearly are other reasons why an infant would be placed in protective custody, but we also recognize that it often is about prenatal exposure and making sure that infants have the opportunity to stay with kin when they can, and to stay with birth parents when they can. So these are actually removals in 2015 out of the nearly 270,000 children, 47,000 were infants. I mentioned earlier that we know that extended families are particularly affected by the opioid epidemic. Of about 1/3 of children who were placed in out-of-home care in which that box was checked, parent has an alcohol or drug issue as a factor in the case, about 1/3 of those children are placed with kin. And it's an increase from about 34% in 2008 to over 40% in 2014. So we recognize the impact that this is having on grandparents and extended family who are caring for children. Again, sometimes because the parent has experienced an overdose death, sometimes because the parent isn't in recovery and can't care for the child. But we salute the grandparents and extended family that are stepping up in this era of the opioid epidemic to care for so many of these infants and young children. We'll switch now to that topic of the prenatal exposure. These are data from 2 different data sources. You see the references at the bottom from Dr. Stephen Patrick, who looked at Medicaid data and healthcare expenditures to track, again, the same time period starting in the year 2000 of the number or the rate of infants that are diagnosed with neonatal abstinence syndrome. That 2013 data is from CDC data that looked at it a little bit of a different way, but again, you see the increasing trend over these years about the increase in neonatal abstinence syndrome, or NAS. We also recognize that hospitals and the healthcare industry is extremely concerned about the number of days that infants stay in the hospital and the costs that they are absorbing, both through their Medicaid plans and for local hospitals that have infants that are staying in the hospital as they are withdrawing from prenatal substance exposure, opioids in particular, during this era. When we look at that Dr. Patrick data that he provided for us of the rates, this is 2012 data, and you see the highest rates in the country at that time of neonatal abstinence syndrome in the east, south, central states of the country, Kentucky, Tennessee, Mississippi, and Alabama, and then the Northeast corridor as the highest rates of NAS from diagnoses in hospitals. So we thought, well, if that's the case and we have this terrific data that shows us the regional rates, wouldn't it make sense that that would sort of parallel where the infants are coming into care? So there may be some data challenges with this as to why, but it's interesting to us, and I think to all of you that are on the webinar, to understand where the highest rates of infants entering out-of-home care are compared to those with the highest rates of NAS. I don't know that we have an answer as to why that is, but we want you to be aware, importantly, in your own community of the rates of NAS as well as the rates of infants who are entering care. Is there a mismatch between that? Does that really show where interventions need to be put in place if we're missing a lot of infants that may have NAS diagnoses, and perhaps they, again, have safety with kinship or other out-of-home care placements, but we need to make sure that state agencies as well as local communities are tracking these data so that they can really get a handle on what is the scope of need and what is the intervention that is being put in place. When we look then to data related to prenatal substance exposure and how many infants by the various types of substances, there are about 4 million births in a year. When we look at the rates from specific studies that have determined the prenatal exposure, this is what those numbers look like. About 600,000 exposed to tobacco, 360 to any alcohol use, about 5% exposed to illicit drugs, binge drinking, about 2% or 80,000 infants, heavy drinking, less than 1%, but about 16,000. Then those that are diagnosed with neonatal abstinence syndrome, that rate of 6 per 1,000 is about 24,000 infants in the country, and a smaller number, or commensurate number rather, that are diagnosed with a fetal alcohol spectrum disorder. Now, why go through those numbers? Because as we turn our attention to the Child Abuse Prevention and Treatment Act and the way that Act asks us in our communities to respond to infants, they ask us to look at those infants that are affected by substance abuse, those that experience withdrawal symptoms, and those that have a fetal alcohol spectrum disorder. Again, if your community doesn't have these data available in order to monitor how many infants should we be talking about that we are identifying and ensuring have safety and well-being in their plans for what happens after discharge from the hospital, we would encourage you to look at the national estimates if you don't have local data, just to get a handle on what does that look like in our community. How many births do we have in our community? Do we have a way in which perhaps the hospitals or the public health agencies have done surveys, have understood what the numbers are in their own community, so that you, again, have a barometer of what that scope is. So when we think about the effects, and we get this question a lot, and we're grateful for the American Academy of Pediatrics that brought together researchers a few years ago to look at data from all of the data published about the short-term and long-term effects across those various substances. They looked in these particular categories for the short-term effects about growth, right, the size of the baby, birth anomalies, so physical changes from that prenatal exposure, the withdrawal that the infant may go through, and neurobehavioral complications in that short-term episode of just after birth. And then they also looked at the literature on growth, again, behavior, cognition, language, and achievement. So Dr. Beneke and Dr. Smith put together this consensus with a host of researchers representing the American Academy of Pediatrics Committee on Substance Abuse, as well as their Committee on Fetus and the Newborn. They looked at 4 decades of research to do this comprehensive review of articles in the literature about what are those short-term and long-term effects. Some key takeaways, we're going to look at those data, but some key takeaways. Opioids have a strong effect on that short-term withdrawal symptoms. That's what we're all hearing. That's what our communities are experiencing. But we need to be aware that other substances, such as alcohol, cocaine, marijuana, nicotine, show more areas of effect on the longer-term outcomes. Prenatal exposure to alcohol has effects in 9 of those 10 domains that I just mentioned. Again, we'll look at this in the charts in just a minute. And that there are some of the substances in which there is not consensus on what that research tells us at this point, or there's just not enough data to really to determine that there is a consensus on that. So you remember those 4 areas I spoke about in the short-term effects of prenatal exposure across the top row: growth, anomalies, withdrawal, and neurobehavior. If you look at each of the substances, the primary substances that are used in our country and may be used during the prenatal period, you see where this consensus statement led to the researchers saying there is a strong effect of alcohol on growth and physical anomalies, no effects on the immediate withdrawal. But what you see right away is that when you look at opioids, they have a strong effect on withdrawal in that immediate postpartum period. So you can cross the rows with each of these substances to understand what the research is telling us about the kinds of effects from the various substances that have been studied. Those are the short-term, and here are the longer-term effects. And again, the longer-term effects, the domains they assessed were a little bit different, still growth and behavior, but they look at cognition, language, and achievement. And one of the things, again, as we said in the highlights, alcohol has an effect in 9 out of 10 of the domains that were assessed. It's the reason why we have alcohol warning labels where you purchase alcohol, where on the bottles themselves you see the effects for nicotine, marijuana, and again then opiates with not a lot of long-term data on opioid-exposed children. Some of that data comes from the 60s and the 70s when there were more infants that were being exposed in those decades to opioids. I'm sure that many of our research colleagues are looking at this now and setting up longer-term studies so that we can fill that those slots of the lack of data. But also in methamphetamine, there have been few long-term studies of methamphetamine's effect on children. And just as a side note, we have heard from many communities, particularly the western states, Montana down to Arizona, that they may just now be experiencing the increase in opioids, but they have continued to be heavily affected by methamphetamine. And within our technical assistance staff for the last couple months, we've been saying we're getting more information about the increase of methamphetamine, and we began to get more technical assistance requests about the effects of methamphetamine. So we don't portend that that will be a wave across the country, but recognizing particularly for our colleagues in those states in the West that may not have been as heavily affected as our colleagues in the Northeast corridor or that area in the South that have high rates of neonatal abstinence syndrome, but that they have been working with families with methamphetamine use disorders for a couple decades, and that hasn't necessarily dissipated in their states. So just wanting to recognize that the various substances may have a different effect in your particular community. And again, it's data that you could seek out to understand what is the impact, how should we be preparing our programs, and our reaction, our policy, and our practice to make sure that we have the services in place to address these particular families. When we look at the effects, it's not just a unidimensional exposure led to those effects. We know from, again, these 4 years of research that there are a big interreaction between many different variables about that child's immediate as well as long-term effects. Certainly, family characteristics. Critical is prenatal care. I remember hearing a lecture all the way back to the time when I was in graduate school in the late 1980s about from an OBGYN and pediatricians who said the most important thing to them was to make sure that the pregnant woman got to prenatal care. That was critical for making sure that the baby had the best outcome and the mother had the best outcome. We certainly recognize that mothers, families, mothers and fathers typically don't use just one substance. And while they may be using an illicit substance, they may also be using alcohol and tobacco. And I remind you of those longer-term effects from alcohol and tobacco. So some of the things that you may be seeing in young children, particularly preschoolers, may be undetected alcohol or other drug exposure that wasn't detected in that immediate post-birth period because they don't have a withdrawal syndrome that's obvious during that postnatal period into their early infancy. We also know that healthcare and other factors in the family as well as in the community in access to services may have a significant impact on the child's long-term well-being. All right, thanks, Nancy. That was a lot of data. That was a lot of maybe not painting a cheery picture for us. So what works? What do we know? We know some things about how to support families with comprehensive services, and we know some things about how to put these services together across service systems in a collaborative effort that becomes family-centered. In part, some of this knowledge was based on some efforts that the National Center has been engaged with for the last several years. What we refer to as in-depth technical assistance. We shifted some of our practice and policy technical assistance those years ago to respond to this increasing number of infants who were coming into out-of-home care and to respond specifically to the increases that we were seeing in opioid use during pregnancy. So some of the information I'm going to share comes from these last several years of working with states and working with communities to focus on opioid use during pregnancy and to focus on recovery of pregnant and parenting women and their families. You see a map of the states that have allowed us to learn with them about the ways in which practice and policy can change and the ways in which interventions can be put in place to better meet the needs of families. And so what have we learned? Some of the services that support families in the prenatal period. States have told us about the need to establish universal prenatal screening, as well as the engagement in substance use disorder treatment during that prenatal period. At birth, what are the protocols? How does the identification of that infant, how is it determined? How does the reaction in the hospital make sure that pain management is happening at the same time that there is an opportunity for mothers and infants to bond? And the importance of breastfeeding when that is possible for this dyad. And then beyond, how do we put services in place? How do we put programs in place that allow that continued support for services and for family planning? What they told us is it really takes this multidisciplinary approach to engage pregnant women and their families in the prenatal period and at birth and in continued support and services across this continuum. We know that in the prenatal period that women are very motivated to make health-related changes, that's enhanced during pregnancy. For all of us on the webinar who are mothers, you know how immediately you began reading books about what you should be eating and not eating, and boy, has that changed in the last 30-plus years. But we also recognize that prenatal care is a touch point for these services. And that the opportunity to engage families in this change process during pregnancy really can't be understated in terms of the outreach that may be necessary and, importantly, the way in which we screen and identify patients. So what do the states tell us about why there is not screening in the prenatal period? From the patient's point of view, we hear a lot about the fear of discrimination, about judgment, the fear of CPS. They don't want to tell anyone they need help if they have a fear that this is something that could lead to a bad outcome for their child, for their family. Sometimes they don't consider their use as a problem. If they have been using for a decade and managing, perhaps they don't see it as problematic. And maybe they've had some previous experiences with the treatment system that didn't go well, and they don't want to engage. There are also some provider reactions that we heard from states. A little bit of denial. My patients don't use drugs. We know from studies, again, all the way back to the cocaine epidemic and to the methamphetamine epidemic, when there have been universal random screens to test prenatal exposure at the time of birth, that the patients that were least likely to be expected to be have positive urine screens at birth, in fact, did. And that those that were often targeted for prenatal screening or for drug testing were those that sometimes had lower rates. There are some data related to that from, again, the cocaine epidemic and the methamphetamine epidemic in particular. Providers would say, I don't have time in this environment of healthcare in which physicians have a very short window to engage with each patient. They don't have time to be able to do that screening, or they don't have a funding source. And some of those things have changed in some states that have put specific screening codes into their Medicaid plan in particular to make sure that screening is accessible and reimbursable to OBGYNs or to nurse practitioners who could be doing the screening. But importantly, they said, we don't know what to do if they screen positive. You know, if a pregnant woman breaks her arm, that OBGYN has someone in their network who is an orthopedist. They know who, maybe they're even friends with them. They have a relationship with that physician who can treat that pregnant woman's broken arm. But if the woman has a substance use disorder, they may not know, and often they don't know, who's in my treatment provider network. If it's an opioid use disorder, who is the provider in my community that provides medication-assisted treatment that serves women, pregnant women with opioid use disorders? So that knowledge about what do I do if they screen positive, I think is incumbent on all of us to make sure that we have those bridges built and that we have the systems in place to ensure that that bridge is there for women during the prenatal period. Some of the things, again, that we know that we recognize early identification can minimize that potential harm to the mother and to her pregnancy and maximize that motivation for change. And again, as I mentioned, some of the literature that says that if it is based on specific risk factors, it may actually lead to some discrimination and miss most of the women with problematic use. So it's important to understand what your prenatal care and hospital protocol is about how they screen. Hopefully this is happening in the prenatal period. If it hasn't happened in the prenatal period, how is that happening at the time of birth, so that it is an effort of engaging families in services. It's about that fear that we need to make sure we can dissipate for families, so that it is an engagement in order to say, I need help. Many families in our country today need help with this. And how do we allow that stigma to be addressed in a way in which we can bring families out of the hiding, if you will, to be able to say, I need help, and here is the way in which we can provide that help. We know that the treatment that is family-focused encourages retention in treatment, that it increases parenting skills and their capacity, and it enhances child well-being. Treatment that supports families says that it's not somebody else's job. I can't tell you in the beginning of our technical assistance efforts how many times we would go to a community and the community would say, well, we're really focused on the parent. Our job is to make sure that the parent gets treatment and is in recovery. And then the Child Welfare Agency would say, our job is the safety of the child. Yes, that's true. You have those requirements, you have those roles. But what we know when we continue to split those families is we're not producing the best outcomes for the mom and the dad, and we're not producing the best outcomes for the infant and the other children in the family. So how do we change? How do we become family-centered in our approach? How do we look at the way in which we have the well-being of the family as our central focus in our collaborative practice? It doesn't happen overnight, but we do know that it can happen, and it's part of the challenge that we have in all of our communities, in all of our states, to ensure that when possible, we're addressing the needs of the family, the individual members of the family, and the well-being of the family, while we are focused on the safety and the permanency for children and the recovery for the parent. How do we put those together in a way that makes sense in our communities? I want to turn our attention now to some specifics about opioid use disorders and medications that are available to treat opioid use disorders. As you see, the National Institute of Health quote, opiate dependence is a medical disorder and pharmacological, meaning medications, are effective in its treatment. The kinds of medications that have been studied, many of you are familiar with these. Methadone has a 50-year research base, buprenorphine more recent, buprenorphine in various combinations, as well as naltrexone in an extended release formula that is injectable, and Narcan or naloxone, which reverses overdose. And this has been a lot in the media, which I think many in communities are very grateful for the awareness for Narcan, naloxone in particular. The substances that are the medications, rather, that have been studied for use during pregnancy are methadone and buprenorphine, specifically the Subutex compound for buprenorphine. That was tested in the mother study, and you see the citation at the bottom of the screen that you can get more information from those researchers who looked at buprenorphine during pregnancy. What does that mean? Why would we use these medications during pregnancy? What, in part, the mother study showed us was that uncontrolled opioid use during pregnancy means that the pregnant woman, as well as the fetus, is experiencing this increase and decrease in the opioids in her bloodstream. We are aware of the effects of withdrawal for adults. Many of us have seen that in our communities. And what the focus of providing medications during pregnancy is to even that out. But again, importantly, in the mother study was that the relapse rates without medication meant that it was advisable for women to receive medications during pregnancy. It is what ACOG and the American Academy of Pediatricians have come out in statements, as well as the National Institute on Drug Abuse, about ensuring that pregnant women have access to medications during pregnancy, importantly to prevent relapse, as well as making sure that the woman has access to prenatal care and also has access to the services that she needs besides the dosing of medications, but the other kinds of services that are needed for her to be in recovery. So we had a question already. What is neonatal abstinence syndrome, NAS? Again, the American Conference of Obstetrics and Gynecologists and the American Academy of Pediatricians have a joint statement, and they say that NAS is an expected and treatable condition that follows prenatal exposure to opioids. The symptoms begin about 1 to 3 days after birth. Sometimes they take longer to appear. And you see the bullet point with the kinds of symptoms that are often monitored to understand the infant's withdrawal and when medications may be needed. The timing of the onset is related to various characteristics of the particular drug used and the time of the last dose. And important again to recognize that most opioid-exposed babies are exposed to multiple substances. So do all babies that are receiving medications during treatment, during the prenatal period, or perhaps are not using, mothers are not using methadone or buprenorphine, but they're exposing babies to heroin, or other prescription drugs, do all of them experience NAS? No. It is a big spread about the babies that actually manifest these symptoms. And that great variability also has variability in what percent, about half, that actually require medications during that post-birth period. So with this wide variation, having practice and policy in place that has that variability to adapt and to be able to meet the needs of the infant and the family becomes critically important. Now, we're very grateful to the researchers at Yale New Haven Children's Hospital who recently, just in this summer, I believe June, in the journal Pediatrics, published their experience that started in 2010 that tried to figure out a better approach to treatment of neonatal abstinence syndrome. And they had several different efforts that they tried in rapid cycle testing. For those of you who are familiar with that, they try to a small experiment using this kind of an approach and then looked at their data and then created more what are called Plan, Do, Study, Act cycles to reduce the average length of stay was one of their primary aims, and that they wanted to reduce that by 50%. If they could reduce the length of stay in the hospital for infants that have neonatal absence syndrome, or NAS, could they reduce that by half? So their multi-year improvement effort came up with various strategies in these 4 categories. Number one, that it was not automatic that all babies got a medication. They used morphine as needed, but they used non-pharmacological NAS treatment. So some of those other strategies that we'll talk about in a minute that all new moms here and can know about: swaddling, breastfeeding, low stimulus environment. It might be thought about as perhaps the opposite of what might be happening in a NICU with a lot of noise and lights, that they made specific effort to have non-pharmacological treatment put in place. And teaching the parents to monitor the symptoms of really helping the parents understand how to soothe the baby, how to understand what that NAS assessment should look like, and how to monitor the baby's symptoms, to ask for help when they needed it, and the staff to be able to help the parent provide that intervention, provide that empowerment to the parents to help their child. And they increased the communication between the units within the hospital, so the NICU and the regular postpartum ward, as well as between doctors and nurses and the other professionals, the social workers and the others who would be interacting with the parent, that they looked specifically about how they were communicating and coordinating services across their disciplines. Again, I would encourage you to look at this issue of pediatrics and to read about what they put in place. Each of those interventions have some specific strategies. So what happened? They decreased the length of hospital stays from an average of 22.4 to 5.9. They decreased the use of medications with babies from essentially almost all babies got medications to 14% who needed medication. They decreased their hospital costs, you see, from $44,000 to $10,000. And important, there were no infants who were readmitted for treatment of NAS, and no adverse events were reported. Again, I encourage you to seek out that article, particularly if you are in the healthcare arena in the audience, to understand what they put in place and how that might be used as a way to look at your own hospital and the way in which interventions are being put in place. So when we talk about family-centered practice, it's really a rethinking about family recovery. We've talked about in the substance use disorder treatment world for a very long time that women recover in relationships, and that we recognize that parents' recovery also occurs in the context of these family relationships, and that services that strengthen the family, support that parent-child relationship, really does help keep parents safe. We also recognize that of children that enter the child welfare system, the majority are in-home cases. The majority are there for allegations of neglect, and that a small number are actually placed in out-of-home care. And of those that are placed in out-of-home care, most return home to their parents. So that when you look at those different categories, about 85% of children with substantiated abuse or neglect either have stayed home with services or they go home. So if that's the case, shouldn't we be thinking about the way we empower parents, the way we engage with families in this much more focused family approach to ensure that they have the best opportunity to care for their children whenever possible? How do we do that? Well, we're at a very important point in our country because we have some windows of opportunities. We have some opportunities through the Child Abuse Prevention and Treatment Act to take some actions about infants in particular. We have these lessons on developing effective and powerful collaboration, and we have some tools for developing collaborative approaches for families. What does that mean? It means that women, particularly those with opioid use disorders, are identified during pregnancy and engaged in prenatal care, medical care, substance use treatment, and the other needed services, and that a plan of safe care for the infant and their family caregiver is developed, reducing the number of crises at birth for babies, families, and systems. So let's talk about what that means for just a minute. What do you mean reducing those crises at birth? If we haven't recognized or engaged our child welfare peers during the prenatal period or just before birth, they get the call from the hospital at the time of birth, and it spins into a variety of responses that they must take. If they had some ability to say, what happened, who is the family, how could we assess what's going on in that last period of time before birth, engaging with their treatment professionals, their peers, engaging with the family to ensure that this plan of safe care was developed before birth, it would reduce a lot of that crisis at birth for the child welfare system. Now, I can see across the country eyes rolling. I really can. Because that seems like, how could we possibly do that? We know that there are communities that have undertaken this effort to make sure that women are identified during pregnancy, that they are engaged in services, and that Child Protective Services becomes part of that partner that provides those services for families. Another window of the opportunities that we have right now is, again, the focus on opioid use disorders in the nation. We have the changes I mentioned to CAPTA. Those actually happened through the Comprehensive Addiction and Recovery Act that was signed into law a year ago, in summer of 2016. And then the CURES Act, which was funded, or passed rather, in the fall of 2016, in which states have received supplemental funding in order to address the opioid use disorders in their states. I'm going to talk just a bit about the Child Abuse Prevention and Treatment Act, because that window of opportunity, when I talk about plans of safe care, that's where this is coming from. CAPTA originated in 1974. It provides different grant opportunities to states to fund child protective services. In 2003, Child Abuse Prevention and Treatment Act was amended, and it said in the report from Congress that the intent of the change in CAPTA was to identify infants at risk of child abuse and neglect so appropriate services can be delivered to the infant and the mother to provide for the safety of the child and the development of a safe plan of care. So this plan of safe care is not necessarily new. It's been in CAPTA since 2003. That the law stated that for states to receive their CAPTA state grant, that the governor's office was assuring that they have policies and procedures and appropriate referrals to address the needs of infants. And you see the categories: born with and identified as affected by illegal substance abuse, withdrawal symptoms resulting from prenatal drug exposure, and that healthcare providers that were involved in the delivery or care of these infants was to notify Child Protective Services, and that there was a development of a plan of safe care. So that dates back to 2003. In 2010, there was CAPTA was reauthorized, and there was a change made in this specific provisions about infants with prenatal exposure, that infants that had diagnosis of fetal alcohol spectrum disorder were included in those categories, as well as some requirements for the state data reports that are submitted from the states to the federal government, as well as, importantly, that their number of infants or children under the age of 3 that they were referred to an assessment for the Part C component of early intervention of the Individuals with Disabilities Act, and that those data requirements included how many of those children were referred and received early intervention services, referred for assessment for those early intervention services. So what happened in 2016? The Comprehensive Addiction and Recovery Act changed CAPTA again, primarily by further clarifying the population requiring a plan of safe care, and specifically removed illegal from that definition. So it now states that infants born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder. Remember back to that slide where I showed you the prevalence rates in those 3 categories? Those are the 3 categories that are specified for which infants we're talking about in the Child Abuse Prevention and Treatment Act. And it required the plan of safe care to include the needs of both the infant and the family or caregiver. This is a big change. In the past, it was a plan of safe care to meet the needs of the infant, and this is what we consider an opportunity to look at family-centered practice as we look at the development of a plan of safe care for the infant in those categories, as well as addressing the health and substance use disorder treatment needs of the infant and the affected family or caregiver. So some pretty big changes that were put into place. It also specified data to be reported by the states as to the extent that's practical through the NCANS data system, and you see the items that are to be reported by the states, and that it specified that there should be increased monitoring and oversight of the state's plans through their annual report, and that increased monitoring for states to ensure that plans of safe care are implemented and that families have the referrals to and the delivery of appropriate services. So that's where we are. Last summer this went into place, and we've been responding to folks who are saying, what does all of this mean and how do we possibly do it? We think, again, that these plans of safe care that are family-centered are this unique opportunity for cross-system collaboration. It's an opportunity to really say and to recognize that child welfare services can't do this by themselves. Treatment agencies can't do this by themselves. Prenatal care providers can't do it by themselves. The hospitals can't do it by themselves. No single agency can go it alone when we're talking about ensuring that families have a plan of safe care that addresses the treatment needs of the parents and the infant. That's a great opportunity, we think. And in the last couple of years, as we have worked with tribes and states to understand how did they do this? How did they go from these various systems to say, we have to put these services together because we can't go it alone? And we categorized their lessons in these 4 different areas about leadership. What did that mean? It was both identifying the champions at the state and the lead agency sort of level, but also the recognition that there were leaders at the front line. There were leaders at the management level of agencies. That leadership meant that all workers in the various systems were really paying attention to and coming up with new practice and policies that could lead to better outcomes for these kids. We also recognize that the engagement of, particularly for child welfare services, to engage with healthcare providers is a new challenge. We typically think about substance use treatment, child welfare, the courts, the various attorney groups. Okay, we can get a handle on that. Mental health, housing, domestic violence, the other kind of critical services that these families need. But this reach out to the healthcare arena was a different kind of thing that needed to happen. But that making sure that those partners are engaged and that they have a seat at the table and that they are meaningfully engaged in developing the practice and the programs and the policies that needed to be carried out in the states and communities. That there was a foundation for systems change through shared resources, not just about the financing of these kinds of services, but the expertise. We all have expertise in our various disciplines, and we need to rely on that other expertise in order to really meet the needs of the families. We talk about systems collaboration defined as a new way of sharing resources that are based on the relationship and focused on results. That these collaborators were able to say, these are the data that we are going to collect that are going to be our scorecard, if you will, about how are we doing. They took the time to understand how many families in our community are we talking about and how many are being served right now. What's that gap? How do we then look at that gap and say what are the systems, the protocols, the training that's needed in order to better meet the needs of families and to improve the outcomes for these infants and their parents. So a specific focus on the integration of being able to bring those various data systems together, often not electronically. I think we all wish that could happen. We could just push buttons and we could get data from various systems. But how do you understand what data your partners have that they can report that allows you to understand how families are flowing through your system and understanding how the gaps are being met and where in your community the gaps are. So the lessons for collaborative practice from the states that worked with us and the tribes in this in-depth technical assistance program focused on substance-exposed infants led us to some of the information that we were able to bring together in February of this year and to invite states to participate in a policy academy. And you see the states that there were 8 states that were selected to participate, as well as 2 states that are currently in the National Center's program of in-depth technical assistance. So their focus has been more specifically on determining some of the things that need to be dealt with for the implementation of the new changes in CAPTA. And what they told us is that the state has various considerations, if you will, things that they need to clarify at the state level. These are not items that are defined in the statute. They are things that are the state level is to be able to determine. For example, the clarity of the definition, infants affected by substance abuse. When do you know withdrawal symptoms? How in your state, how in your community are you making those determinations about how that identification will happen? Clarifying identifying that notification procedure. Note that it doesn't say in CAPTA that that's a child abuse report. Knowing the difference between a notification has happened to CPS and what CPS statute is in their own state about how they react to that notification is critically important for the treatment providers and for the hospitals and the medical community to understand what that means in terms of the notification procedure. So which populations of families? We've heard a lot of conversation about women who are participating in medication-assisted treatment. Are they included in families in which there is a notification to be made in the, to CPS? Those are state decisions about which populations, and how CPS handles those particular cases are state decisions. So some of these, again, the state considerations become very important, and to understand what that state statute is and the current policies and procedures in order to see, well, is that the best way we should be doing that in this era of opioids? Is that the best way that we should be engaging families that the mom is in medication-assisted treatment? Is there a better way that we could be doing that? And that delineation of what is in that plan of safe care becomes critically important as the organizing way of looking at these various systems that are coming together in this approach. And then how do the states respond to those challenges of data collection and the reporting systems that need to be submitted in their annual report to Children's Bureau? And then they told us that there are some things that the local communities need to do. What is the procedure for prenatal screening in public health clinics, in prenatal care providers? Are the OBGYNs engaged? Can we look at the information from the federal associations or the national associations of OBGYNs and pediatricians and apply that in our community? How does that identification happen? What does that mean in terms of risk and safety and the kinds of protocols that are operating in Child Protective Services to understand child risk and safety? Is that different for the different populations of women, women who are engaged in treatment, women who may be taking a prescription drug that may have withdrawal symptoms, but she doesn't have a substance use disorder. And then the population I think that we hear most about are families in which there is a substance use disorder and she's not engaged in treatment. Can we look at those different populations of families and think about their needs and their strengths in a way that provides a coordinated approach across service systems? And then, again, importantly, what is this plan of safe care and how is it different from anything that we may have been doing in practice now? So understanding at the local level who is responsible, what is the timing, what are the components to go into it, who implements, who monitors, what's the length of time for monitoring. These are all in some ways very exciting opportunities for us to rethink the way in which we are working with this set of families in a way that really engages them in the change process that may be needed. So what did we think? What did we hear from states about implementing the plans of safe care? That ideally it's developed prior to the birth event. We don't wait until the baby is born to say, who's the baby going to go home with? What happens? How is the baby going to be treated if the baby does have withdrawal symptoms? Is the hospital prepared for that? Are grandma and the aunts and others that are going to be in the home prepared to understand how to assess and to monitor symptoms of withdrawal? How do you bring together all of the service systems that we need to have in this multidisciplinary approach? How do you think in each of these intervention points, again, during pregnancy at the birth event and during infancy. And what does family-centered mean in your community? What does family-centered mean if we are looking at the well-being of the family and the requirements that each of the service systems have, but recognizing that the child and the parent may be best served if we can look at their individual needs as well as the family as a whole. I probably can't emphasize this enough because I hear it a lot. I hear a lot that if the parent completed treatment, that is family recovery. It is critically important for parents to be engaged in this change process in treatment. Don't let my statement seem that I'm minimizing that. But it's about making sure that parents have the skills and the competencies that they need, that they have the connections to resources, that other family dynamics that may be at play, mental health issues, domestic violence. The parent's recovery encompasses all of that. And that child well-being is not just about safety, but that child well-being is about looking at those various components for these infants with prenatal exposure, that we're making sure that we're focused on the various components in which there may be effects that we may need to put some services in place to address. And that there are some basic necessities that parents and families need to ensure that they're able to care safely for their children. So family recovery takes each of those aspects into account and says, how do we put that together in a plan? How do we put that in together so that that overall needs, engagement, strengths of the family are brought together to say, this is what we are doing in this plan, that we're going to bridge the systems and the services. Again, we heard from the states that have been working on this. Identifies the family's overall needs, identifies the lead agency. So there isn't anything in that CAPTA law that says that a treatment agency can't develop the plan of safe care. A treatment agency who has a pregnant woman engaged in treatment, I think, has a responsibility to reach out and say, let's create this plan of safe care so that we know before birth what's the plan. Who will the infant be discharged to? Are there the right supports in order to support you going home to be able to care safely for the child? It brings together these various plans. Everybody has their assessment and their treatment plan, the hospital discharge plan, the infant care plan, the substance use disorder treatment case plan, the pre- and postnatal health care for the woman. How do you bring that together to make sure that we're not letting infants, if you will, fall through the cracks of these various plans? Who in the community steps up and says, we're going to do this a little bit differently so that we make sure that the family, that the infant has the best chances for being able to live together as well as to be safe. So again, from the states that we've been working with, that it's a little bit different than various components of the plan. Number one, it includes both the parents and the infant's treatment needs. That it includes the other identified needs that are not determined to be immediate safety concerns. That it involves the systems outside of child welfare. Again, ideally, it's developed in the prenatal period before the birth of the infant, and that it continues beyond the child welfare assessment if the case isn't promoted or move over to ongoing services. So how do you put that in place so that that is the response for families in the community? I'll go through these a little bit quick. You're going to be able to get a PDF version of the PowerPoint slides. So you'll have these domains and the types of services in support. Again, This is from the states that we have been working with as they have grappled with what are the components of a plan of safe care. And we would encourage you to consider these different domains: the primary health and OBGYN health, the kinds of services that need to be put in place for substance use and mental health disorders, prevention, intervention, and treatment, the parenting and family support, as well as for the infant, the health care needs of the infant. Is the infant linked to a medical home, a pediatrician, a primary care provider? How do you look at those child developmental milestones and ensure that the coordination of early care and development and educational programming is pulled together when needed for these particular infants? We have gleaned then from the states that we've been working with some examples. Several of the states have proposed, a couple have passed the state-level statutes to implement the changes in CAPTA. Some states that have grappled with what is those definitions of affected by mean. What are the hospital protocols? How do they screen? If the woman comes to the hospital to deliver and there isn't information about she's engaged in treatment, what's the hospital protocol? And what's the protocol for CPS when they get that notification? What's the policy? Some states and communities are developing specialized units that get the notifications, and they have their assessment that is being conducted in a way that may be a different track than their standard services of child abuse reports. What's the plan of safe care policy? Who develops it? Who implements it? Who monitors? What kinds of plan of safe care templates need to be put in place across these service systems? And again, some examples of states who have made changes in their SACWIS or their child welfare data system in order to provide the data that are required through these changes in CAPTA. Let us also mention that the 20th Century Cures Act and the Opioid State Targeted Response Grants that were developed through the Cures Act that passed, as I mentioned, in the fall of 2016. All of your states have received their first allotment of money to supplement opioid use prevention and treatment. There are some states that have prioritized the child welfare population, and we would encourage all of you to be in touch with your state and local agencies about how to make sure that families in the child welfare system, when needed, have access to these supplemental funds for opioid abuse prevention and treatment. The single state agencies in the state were the recipients of those grants, and there are a wide range of kinds of uses that the state could propose that how they use their opioid grant funds. So if you're not familiar with that in your state, I would encourage you again to be in touch with your local or your state agencies to understand how those allotments are coming out through your state. We also want to make sure that you're aware of a resource that was published last summer from the National Center on Substance Abuse and Child Welfare. It is, you see the cover and the title. We provided ways in which the various service systems could come together and look at their current systems to do some self-assessment and to provide those in a collaborative planning guide. So each of the systems have a series of questions to do some reflection on how does it work now, and to identify those gaps about how they would like for it to work differently. It also includes a case study from what's known as the CHARM Collaborative. This is a group that originated in Burlington, Vermont, and has now a decade of experience of identifying pregnant women with opioid use disorders and engaging them in treatment and making sure that plans are in place before the infant's birth to ensure that that a plan is there for the safety and for the well-being of the family. We also want you to be sure and visit the National Center on Substance Abuse and Child Welfare's website. There is a specific page about the webinar series that we created previously on various aspects of opioid use disorders and medication-assisted treatment, treatment for pregnant women that goes into a great deal more depth. But a host of resources that are available. Sometimes folks say to us, how do we get started? We say, look at the webinars, bring your collaborative group together, watch the webinar, and then make some plans about what that means in your own community. There is also a wealth of information that is available from SAMHSA on each of the medications that are available to treat pregnant and parenting women, fact books, ways in which to understand treatment for opioid use disorders, and treatment improvement protocols that are available, as well as a locator system to find physicians that are certified to provide buprenorphine in your community and in your state. A lot of resources that are available from Children's Bureau in the policy manual, the information memos, and the program instructions that have been issued specific to the implementation of the Child Abuse Prevention and Treatment Act, as well as guidelines and resources that are available from various national organizations and the healthcare arena in particular that are available to you. Again, we will be emailing to you a PDF version of this PowerPoint so that you will have these links available to you. And if you are not aware, the National Center has free CEUs available through its online tutorials. Again, last summer we updated those tutorials. We have over 70,000 people in the country who have taken the tutorials. There are 3 different courses. One is a guide for child welfare workers, the second for substance abuse treatment professionals, and the third for legal professionals that are, I think, very instrumental in the basic information that child welfare and treatment and those that are working in the court need to know about this particular population and about working across systems. Well, I said there was going to be room and time for discussion, and you know, it's me. I talk a long time, I'm afraid. I hope that you found this informative. I see that we're just a minute from the time that we are scheduled to end, and I don't want to take your time any further. We would encourage you to please be in touch with us. First, when you sign off of the webinar, you will be asked to take a very short evaluation of the webinar, which we use to help improve our services at the National Center. I hope you will please take a moment to do that. And then, please be in touch with us. You see our toll-free number, our website, the way to email us. If you have specific questions that unfortunately we didn't answer today through the formal presentation, please be in touch. Please visit the National Center's website. You see the website address for lots of information about various aspects of substance use and child welfare and courts and this newer information specific to opioids and engaging in the healthcare arena. Thank you so much to our project officers and to SAMHSA and the Administration for Children and Families for your leadership in this effort. And thank you all on the line for your time and attention today. And thank you for everything that you do for our country's children and families every day. We'll talk to you all real soon, I hope. Bye.